Welcome, everybody. We're just going to give everybody about a minute here to join, and then we'll get started on the AML webinar right on the hour here. So feel free to post any questions in the chat as we go. We're just giving everybody a minute here to join, and then we'll get started shortly. All right, so welcome everybody to the 2022 National Virtual Leukemia Conference. This is a one-of-a-kind conference addressing the unique needs of the blood cancer community and offering the latest information, tools, and resources to help support Canadians affected by leukemia. The Leukemia and Lymphoma Society of Canada is proud to introduce today's presentation titled Acute Myeloid Leukemia, AML, what it is, how it's treated, and what's on the horizon. In this session, Dr. Ryan Stubbins, fellow at the BC Cancer Genome Sciences Centre and the Leukemia BMT Program of BC, will discuss what AML is, how it develops, how it is treated, and some of the most promising new treatments for the disease. First, let me introduce myself. My name is Natasha Sani, and I'm the Community Services Lead for the BC Yukon region with the Leukemia and Lymphoma Society of Canada. I'll be moderating today's online event. Since there are many of you, we invite you to type your questions and comments in the question box of your Zoom webinar panel throughout the presentation. An LLC staff member will be monitoring the questions, and at the end of the presentation, I will read some of your questions aloud during the question and answer period. Due to the large number of participants and our limited time today, we may not be able to answer all questions. Please also note that our speaker cannot answer specific questions about a person's health status, and case-specific questions will not be read aloud during the Q&A period. If we do not get to your question during the live presentation, a community services lead will contact you directly after the webinar. Today's presentation will be recorded and will be available to view again on our website. If we could please move to slide 2. If you have a lot of questions right now, or you cannot find what you're looking for, you can talk to a community services lead in your area and receive personalized assistance in finding answers to your questions or ways to address your concerns. Our community services leads are here to help. You can reach out to us by calling toll-free at 1-833-222-4884. Next slide, please. We invite you to visit our new website, bloodcancers.ca. Our goal is to better serve the community and offer an improved experience. On our website, you will find all of our past webcast recordings, our podcast channel, information sheets, practical tools to help you navigate the cancer experience, and so much more. You can visit us at www.bloodcancers.ca. Next slide, please. Reading about people's experience with their cancer can be a source of support and help build community when facing a blood cancer diagnosis. On our website, you can read testimonials from cancer survivors who have found new meaning in their lives. We invite you to visit our website and read some of their stories. Next slide. All right, it is now time to introduce today's speaker, Dr. Ryan Stubbins. Dr. Stubbins is currently a fellow at the BC Cancer Genome Sciences Centre and the Leukemia BMT Program of BC. His clinical and research interests are focused on the myeloid malignancies, including myelodysplastic syndromes and acute myeloid leukemia. He completed his medical training at the University of Saskatchewan and the University of Alberta, where he also completed a Master of Science in Translational Medicine. He subsequently completed his clinical hematology training at the University of British Columbia. He was awarded the Leukemia and Lymphoma Society of Canada Clinician Scientist Award to investigate precision medicine approaches to epigenetic therapies in myeloid malignancies. Thank you for being here today, Dr. Stubbins. I'll pass it over to you.
Okay, great. Well, thank you very much for the invitation today. So today we're going to be talking about acute myeloid leukemia, and I want to keep it fairly interactive. So, I have a few slides and then I want to leave lots of time for questions. But we're just going to go over, kind of the whole landscape of acute myeloid leukemia. So really, what is acute myeloid leukemia? And how common is it? So leukemia in overall as a group is the 12th most common cancer in Canada. About 6,700 people are diagnosed with a type of leukemia about every year, which means that there's about a lifetime risk of about 1.5% of being diagnosed with a leukemia. And acute myeloid leukemia is one of the relatively more common subtypes of leukemias. So we actually looked in British Columbia about trying to find out how common is acute myeloid leukemia and how many patients are we seeing each year with acute myeloid leukemia. And what we saw is that we were seeing about 225 new patients per year with acute myeloid leukemia. And then when we looked over time, kind of starting from the 90s going up to today, we could see that, we're generally seeing more people with acute myeloid leukemia. And that's primarily being driven partly by the aging population, with most of those patients being over the age of 60. And one of the things we do know is that acute myeloid leukemia is very strongly correlated with age, and that the majority of people who get acute myeloid leukemia are older at diagnosis, although those younger people can get it as well. So this worked out to be about 4.11 cases per 100,000 population, which is pretty similar to some of the large databases from the United States and other places, suggesting that we're seeing a similar number of patients in British Columbia and Canada in general. And as I mentioned, acute myeloid leukemia is more common in people over the age of 60 for a number of reasons. So why do people get AML, and what happens when people get AML? So in the bone marrow, there are these things called stem cells. And so the blood is a bit of a unique organ, and it's unlike any of your other organs in that your body needs to make new blood throughout your entire lifetime. So, and your whole blood system will replenish itself every couple of months, versus when you think about your heart or your lungs or things like that, they don't need to continually replenish themselves throughout your life. And so in order for the blood to perform this special function, there's these special cells in the bone marrow that are called stem cells. And what these can do is throughout your lifetime, these cells can regrow and then replenish the blood supply. And then these stem cells turn into three major types of blood components. So there's the red blood cells, the platelets, and the neutrophils. The red blood cells carry oxygen throughout the blood, the platelets clot the blood, and the neutrophils can fight infections. So what happens with AML is that the stem cells get a mutation in the DNA. And this can happen for a number of reasons. But what happens is that the stem cells get a DNA mutation, and then this leads to those stem cells growing out of control and then turning into leukemia cells. And then what happens is the leukemia cells then fill up the bone marrow and sort of crowd out the normal healthy cells of the bone marrow. And then you have a decrease in your red blood cells, decrease in your platelets, and decrease in the neutrophils. Sometimes the leukemia cells can grow so fast that they start to spill out into the blood. And then what happens is people get symptoms related to typically low blood counts. So if they have low red blood cells, they can get anemia symptoms, so tiredness, shortness of breath, or dizziness. With low platelets, people can get bleeding. And then with low neutrophils, people can get infections. So those are some of the most common symptoms that people can get related to AML. And so how does AML relate to other kind of blood cancers? So, AML is in some ways, it's related closely to other types of blood cancers as well, in particular things like the MDS, or myelodysplastic syndromes, as well as the myeloproliferative neoplasms, or MPNs. And both MDS and MPNs can turn into acute myeloid leukemia. And so some people will, prior to their diagnosis of acute myeloid leukemia, have a previous diagnosis of MDS or an MPN. Although some people's acute myeloid leukemia will just develop directly and it won't go through these other stages. And we know that kind of behind all of this, there's this disease called clonal hematopoiesis, where we can actually detect DNA mutations that are also found in acute myeloid leukemia at kind of an early stage in actually a surprising number of people in the general population. And so if you look at people over the age of 70, up to 10% of people, we can detect an early DNA mutation that is related to either MDS or AML. And we call this clonal hematopoiesis. And we think that one of the things that can contribute to AML development, as well as MDS and the MPNs, are this kind of slow acquisition of these gene mutations over the course of years that can eventually lead to AML. But every individual's course to get to AML is slightly different. So some people go through these early stages, some people it happens more quickly. So it's a bit different for every individual patient. And, a lot of people ask, well, why do people get AML? Why does this happen? So in about 5 to 10% of people, we can identify previous exposure that may have led to this. In particular, chemotherapy for other cancers, radiation exposures, sometimes industrial chemical exposures can cause this. So in about 5 to 10% of people, we can identify a specific sort of exposure that caused it. AML or MDS can also be inherited in some cases, where in about 5 to 10% of patients, we can find a gene mutation that the patient actually had inherited and that had been with them their whole life that eventually predisposed to this happening. Usually people in that circumstance have a family history of cancers, and often they'll have a family history of blood cancers specifically. So how is AML diagnosed? So the most common symptoms people can have that lead to this diagnosis are related to the low blood counts. As I mentioned, tiredness, dizziness, shortness of breath, bleeding, or infections. Sometimes we'll find AML incidentally on blood work that's done for other reasons as well. But a bone marrow biopsy is the only test that can confirm an AML diagnosis and is also important for establishing the prognosis. And so you can see here when we look at under the microscope from a bone marrow biopsy, you can see these are what we call the blasts or the leukemia cells. You can see here on the left, this is what a normal healthy bone marrow looks like, where you have all different types of cells there. You have the red blood cell precursors, you have the granulocyte precursors. But here on the right, you see what happens in a AML bone marrow is that gets filled up by these leukemia cells or blasts. And so we can tell that under the microscope. So what's the prognosis of AML? And so, this is always a hard question to answer because it's very individual, and each individual patient has a different prognosis, and most of that is defined by the type of genetic changes we see in the leukemia. And really the AML subtype or the particular type of leukemia, because within AML, there's a number of different subtypes. And what subtype people have is largely defined by which gene change is there. And we generally break people up into 3 risk categories, what we call the favorable risk, the intermediate, and more adverse risk. And so, a combination of the genetics of the leukemia plus other factors all kind of come together to establish the prognosis. So that's basically to say that there's a wide range of prognoses and it's sort of different for each individual. And so how do we treat AML? So, because the prognosis and the type of leukemia people have is so individual, the treatment also needs to be individualized and really it needs to be tailored based on many factors. So one important thing is what sort of AML subtype a patient has, as well as how well we think that the patient can tolerate treatment, as well as what kind of symptoms that you would have, as well as what are the goals of your treatment. And so one important thing to establish upfront with your physician is what really are your goals of treatment, right? And this is different for every person. So in many people, it can be things like wanting to reduce or eliminate the need for blood transfusions. Sometimes it can be reducing symptoms. Sometimes it can be, improving or maintaining quality of life. And of course, putting the AML into remission, is an important goal for many patients as well. So one of the common AML treatments that we use for specific types of AML, and so, again, just keep in mind, each of these are individual. So these treatments don't necessarily apply to every person, but these are some of the treatments we can use for people with AML. So there's one very special type of AML called acute promyelocytic leukemia, or APL, that has this particular gene change called PML-RARA. And it produces these leukemia cells that have this very kind of particular look under the microscope. And this has a unique treatment that really only works for this specific type of leukemia, but it tends to be very effective. And it's a combination of a pill medicine called all-transretinoic acid, as well as an intravenous medication called arsenic trioxide, or ATO. And we tend to see very high efficacy rates with this treatment in this particular subtype of leukemia. But this only makes up a small fraction of the the AML cases that we see, but it has a very particular treatment. Another common treatment that people might receive is high-dose chemotherapy. And there's several different types of high-dose chemotherapy regimens that we use. But it's important to know that this high-dose chemotherapy may not be appropriate for everyone. And there may be some patients that, may for their health, based on their health or other factors, they may not be able to tolerate high-dose chemotherapy. But in some patients, it's an important part of their treatment. And the most common drugs that we would use are a combination of intravenous versions of either anthracyclines, things like daunorubicin, or cytarabine. Usually we give this as an induction and then cycle and then follow with consolidation cycles. And in some people, the high-dose chemotherapy alone can be enough to put their disease into a long-term remission, in particular people who have more favorable risk AML. Another common AML treatment that we're using a lot more now are what we call the hypomethylating agents, or azacitidine. Often now we're combining this with another medication called venetoclax. And this we call kind of a lower intensity chemotherapy approach, but it can be very effective in some patients. So azacitidine is a drug that is given it's given under the skin for 7 days per month. Sometimes people get it continuous for over a week. Sometimes it's broken up into 5 days and 2 days. And then the venetoclax is a pill that's taken for usually between 3 to 4 weeks every month. And this is a little bit individualized for each person. And this has shown some high response rates, and it tends to be easier to tolerate than the high-dose chemotherapy. There's also recently been an oral version of the azacitidine that's been approved, but we don't have that available everywhere in Canada yet. But eventually we probably will have more access to the oral version of azacitidine, and then that would mean this would be a potentially all oral regimen for people at some point. The other thing that we're using more and more now are targeted therapies. And so unfortunately, there's a little error on this slide, but targeted therapies, if people have specific gene mutations, in particular in genes called FLT3 or IDH, we do have specific pill drugs that we can use to target those mutations, and then those can also be effective. Those treatments are either used as combination treatments with either chemotherapy or the azacitidine, or sometimes they can also be used as standalone therapies. So we do have new targeted therapies that we're using as well for patients with AML. The other treatment that many patients with AML will get that some patients with AML will get is called a stem cell transplant. And there are some patients who will need a stem cell transplant in order to achieve a longer term remission. And so the process of stem cell transplant is quite complicated, but it basically involves identifying a donor and then giving patients chemotherapy, and then subsequently giving them the donor cells. And in general, for this to be successful, the AML needs to be in remission, or it needs to be in some sort of a response to the chemotherapy. And the donors we use can either be related donors, unrelated donors, or sometimes half-match or half-identical donors, or occasionally cord blood. So as I mentioned, this is quite a complex procedure, and really people need to be very carefully selected for this type of treatment. And not everyone's bodies would be able to tolerate a stem cell transplant, but in some patients it is an important part of their treatment. So one other thing that there's been a lot of news about and a lot of media attention are CAR T cells and immunotherapy. And so these are special treatments which utilize the immune system to attack the cancer, where basically the patient's lymphocytes are genetically modified. And these are kind of a living drug where the T cells will actually attack the cancer. So these have become important treatments for lymphoma and some types of leukemia, but we don't yet have them available for AML, although there are still some CAR T cells for AML that are in the early stages of development. But these haven't quite hit the mainstream yet. But there certainly is a lot of interest and development in this area. So are there things we can do to prevent AML? So at the moment, we don't have any proven ways that we can prevent the development of AML. But in general, the best things people can do is to live an overall healthy lifestyle. So things like avoiding or quitting smoking, maintaining a healthy diet, and regular exercise. So as I mentioned, we've now identified that we can detect some of these leukemia gene mutations earlier on in the course of development of AML, and this thing that we call clonal hematopoiesis, but we don't really have good treatments for it yet. But at some point in the future, we may have treatments that can help can either detect AML early or help prevent it from occurring, but that won't, we don't have anything that works at this point, but at some point in the future, potentially. And so what's lifestyle measures can help people who have AML? So there's a lot of important lifestyle factors to think about when you're considering your AML diagnosis and your therapy. So one important thing is you need to avoid things that can harm your other organs or potentially cause inflammation, because both of these things can cause problems in terms of tolerating treatment, as well as we do know that inflammation and other comorbidities can result in the AML potentially, having a harder time controlling the AML. So things like avoiding smoking, avoiding heavy alcohol use, as well as being careful about avoiding infections, especially in the time of COVID. So regular hand washing and avoiding people who are sick are all very important for people with AML, especially because we know that AML also suppresses the immune system. And one common question I get is, what kind of diet should people with AML eat? So it's important to really optimize your diet and nutrition as part of your AML treatment. And so what kind of food should be avoided? So because patients with AML have a low immune system, you need to avoid things like raw foods, and so things like sushi or oysters, because especially if the blood counts are low, because there's an increased risk of getting an infection from those type of raw foods. Salads can be healthy, but you need to be cautious just because, salads can transmit bacteria. So you need to make sure that if you are having a salad that it's the lettuce is well washed and that it's, comes from a reputable source. Then also avoiding unpasteurized milk products, so things like raw milk. Pasteurized dairy is okay, but just avoid any unpasteurized milk or cheese products. And so what kind of things should patients with AML be eating? So obviously fruits and vegetables are important to your overall health, but again, making sure they're well washed, but a good intake of fruits and vegetables are very important. The other thing is lean proteins or high protein plant-based foods are really good because you want to make sure that you maintain adequate protein intake in order to keep your muscle mass up, as well as healthy complex carbohydrates. Things like brown rice are a good way to get more calories. And so it's important to make sure that you're taking in enough calories and eating enough when you have an AML diagnosis, because in general, we don't want people who have AML losing a large amount of weight, especially while they're on treatment, because this can sometimes result in lower muscle mass and it can cause difficulties with patients tolerating their treatment. And so sometimes patients with AML will have a hard time eating just due to nausea or low appetite. So if you're experiencing this, make sure you talk with your doctor or dietitian to help optimize your intake. And there's several strategies we can use to optimize this. So things like anti-nauseant drugs, medications, or different types of foods. And so it's important to make sure that you're getting enough nutrition in. And, but this can be difficult for people as well, just because sometimes there's just not the same appetite. But there's ways we can help people with this. And so how much should people with AML be exercising? So exercise and just maintaining your activity level is an important part of your AML treatment, because again, this will help prevent muscle loss and help keep your overall health intact. And so, how much exercise should people with AML do? And so really this answer is different for every individual person. So really it's about listening to your body and doing what you're comfortable with. Even light activity is good. So for a lot of people, this means going for a walk outside or just doing chores around the house. And all of that's good. The important thing is to just, do as much as you feel comfortable doing. One question I get a lot as well is, are there supplements that are good for AML patients? So there's no real specific dietary supplements that have been shown to help treat AML. But if you do decide to take supplements or herbal medicines, just make sure you let your doctor and your pharmacist know, because these can sometimes have drug interactions, especially with that venetoclax pill. So the venetoclax pill has a lot of drug interactions. So just make sure you let people know if you're going to take supplements. Vitamin D is often a good idea. And many people, especially in northern climates like Canada, are vitamin D deficient. So that's often a good idea to take. And then what about COVID-19 and AML? So obviously COVID-19 has had a major impact on patients and providers in the healthcare system, but it's important to really still pay attention to your medical needs during this time. And also to remember that patients with AML are immunosuppressed and potentially are at a higher risk of complications if they do catch COVID-19. So it's important to get vaccinated and make sure that the people around you are vaccinated. And this is the best thing you can do to protect yourself from COVID-19. And so if you do get COVID-19, it's important to mention that to your doctor and let them know, because patients with AML often will qualify for certain treatments that can help reduce the risk of getting severe complications from COVID, like Paxlovid or remdesivir. So if you do end up getting COVID, just make sure you call your hematologist or call your family doctor and let them know, because you might be eligible for some of these COVID-19 treatments. Now, what about mental health and AML? So this is a very complicated subject that, I think unfortunately is somewhat understudied, but we do know that anxiety and depression are quite common in AML patients. For example, in this particular study, they found that patients with AML, almost 40% of them had anxiety as compared to about 13% of healthy controls. And almost 28% of them had symptoms of depression as compared to 10% of healthy controls. So it's important to really try to seek out support during your diagnosis and treatment. So whether that's family or friends, counselor, social work, your treatment team, and also patient support organizations, it's important to think of, pay attention to your mental health because it's an important part of your overall care plan. And so what's the future of AML treatment? So there's a lot of research going on in AML right now. That's helping us understand, what causes AML and how we can better treatment and how we can better treat AML. And so really support from organizations like the LLSC has never been more important for this, just because, it's the funding environment gets more difficult every year, but it's important that we really need to make sure that we continue to prioritize research and developing new treatment approaches for patients with AML. So one important part of AML research are clinical trials. And so what is a clinical trial? So a clinical trial is a way in which we systematically test new treatments. And generally these treatments that we're testing in clinical trials have many years of supporting research behind them, often decades. So, usually these are treatments that have been at least tried in other forms, but then the clinical trial is the way that we're testing it to see if it actually works in real time. And so, participating in a clinical trial can sometimes give you access to the newest treatments available, as well as it can help advance knowledge about how we treat AML. So for some patients, a clinical trials can potentially give you access to new drugs. So it's something to think about or talk to your doctor, and depending on your individual circumstance. And so really, what's the future of AML treatment? So a couple of things that we're seeing, a couple trends, is that one of them is we're seeing more combination therapies come on to the scene. In particular, we're seeing more interest in triplet type therapies. So remember how I talked about azacitidine and venetoclax, and then the targeted therapies. There's now some studies that are looking at combining all three. So azacitidine, venetoclax plus a targeted therapy. And there's ongoing trials with that. As well as there's some trials looking at adding other treatments to high-dose chemotherapy like venetoclax. We also have more advancements in how we monitor and prognosticate in AML. And in particular, the use of something called minimal residual disease is becoming more important, where we can detect very, very tiny amounts of AML, and that helps us establish the prognosis, as well as whole genome sequencing approaches. The other area that there's a lot of development are new ways to prevent relapse, including maintenance therapies. The other thing is that we're seeing some new immunotherapy drugs that are entering clinical trials, things like magrolimab, TIM3 inhibitors, or CD333 bispecific antibodies. These are all very kind of interesting new immunotherapy drugs that we're seeing tested, as well as I mentioned, there's some new CAR T cell therapies that are still in their very early phases of trials, as well as new targeted drugs like RAS inhibitors. So there's a lot of development happening. There's a lot of clinical trials. This is an area that's rapidly evolving, and we're going to see a lot of new treatments come online in the next, 5 to 10 years, I expect. So, kind of conclusions. So, AML is a complex condition, and the treatments for each individual patient need to really be tailored to their individual circumstance. And there's many factors that need to be taken into account. While some patients can achieve a long-term remission, there's still a significant amount of work we need to do to improve outcomes in AML. But new treatments are coming on at a faster rate than we've ever seen before. So, we're looking forward and looking at, really trying to move the dial on outcomes here. So, okay, so maybe I'll open up for questions.
Awesome. Thank you, Dr. Stubbins, for sharing your expertise and insight with all of us today. That was great. So it is now time for our question and answer period. So if you haven't done so already, be sure to use the question box in your Zoom webinar panel to type any questions you may have. And just a quick reminder, as we mentioned earlier, due to the large number of participants and limited time, we may not get to all the questions, and also that our speaker cannot answer specific questions about a person's health status. Unfortunately, this is not a private consultation, and if we do not get to ask your question during the live presentation, one of our community services leads will contact you directly after the webcast as well. All right, Dr. Stubbins, so we have a few questions here. I'll start with this one. Is AML the unavoidable eventual progression for CML patients? If so, any advice for avoiding or postponing that supposedly undesirable progression?
Yeah, so I would not say, so AML is not an inevitable outcome for CML. Only a small percentage of patients with CML develop AML. And the best thing that can be done to prevent that from happening is achieving good control of the CML through basically effective treatment of the CML. So we know that if patients are able to get on a CML treatment that can suppress the CML and they maintain a good molecular response to that, then the risk of AML progression is much lower. So I would say the best thing to do to prevent that from happening is really effectively treating your CML, or treating the CML.
You. Next question here. Are stem cell transplants often denied based on the health of the patient? After how long on average after the induction phase do transplants happen?
Yeah, so with stem cell transplants, there's two things we need to take into account. So the first one is, does the risk benefit favor a stem cell transplant or chemotherapy? And that decision will be made based on the prognosis of the AML or the risk category. The second thing is the stem cell transplants, it is a difficult procedure to tolerate and it can be quite toxic. So we do need to really carefully select patients. And there are some patients that, just based on their comorbidities or other organ function issues, we think that the risk of the transplant ends up outweighing the benefit. So, as I mentioned, the stem cell transplant, it's an individualized decision. And the factors we need to take into account are, first of all, the type, the prognosis of leukemia. And the second thing is how well we think the patient could tolerate it.
Thank you. Okay, so we have another question here. After 10 years of polycythemia vera has become AML, is this a secondary cancer? Does this version of AML have any unique treatments or outcomes?
So secondary AML we generally define as an AML that's developed after a person has had a prior MPN or MDS. And so with polycythemia vera is in the family of the MPNs. So that would be a type of, so AML that's developed after polycythemia would be considered as secondary AML. There are some, we don't have many specific targeted therapies for secondary AMLs at this point, although there are some newer chemotherapy approaches that are being tried, so things like a drug that we call Vyxeos or CPX is one. But in general, the treatments for secondary AML are quite similar to patients who develop AML just without a previous diagnosis.
Does AML produce a high leukocyte count?
So AML can produce a high leukocyte count. And so, as I mentioned, the blasts grow in the bone marrow and they crowd out the normal bone marrow. And sometimes earlier on, they don't go out into the blood and they just fill up the bone marrow. And so sometimes people will actually have low counts. But then as those leukemia cells continue to grow, they can sometimes spill out into the blood and then create a high white blood cell count. So the blood count can either be high or low. It just depends on whether or not the leukemia cells have spilled out into the blood.
Is there a timeline for a zizazidine pill form in Canada? Sorry, it's heavy mispronunciation.
So the oral version of azacitidine, it's different and it depends on the province. So we don't have precise timelines yet on provinces. In BC, we're starting to get more access to it now, but it'll basically, the decision is being made on a province by province basis. So.
Okay, perfect. And then are you able to talk about Mylotarg and what it is used in AML treatment and what are possible long-term side effects?
Yeah, so Mylotarg, Mylotarg is another drug that we do use in AML treatment. Its use has been it looked at in a few different contexts. Usually it's used with high-dose chemotherapy in combination. And it seems that particularly for patients with favorable risk AML, it might have a benefit, but there's potentially benefit in other groups as well. And so the main side effect it can have is sometimes it can cause liver issues, so the liver needs to be monitored closely. But in some patients, depending on the particular subtype of AML, it can potentially be effective, particularly in combination with chemotherapy treatments.
Okay. So we have a question here about stem cell transplant. So for a stem cell transplant, is a fully unrelated donor preferred to a haploid donor?
So generally speaking, a fully matched either related or unrelated donor is the first kind of preferred choice. Haploidentical donors can be used safely, but the risks are slightly higher than a fully matched donor.
And then we have, how frequently is AML diagnosed in children, and how do the treatment advances benefit them? How have these advanced in about the last 5 years?
Yeah, so AML is still relatively rare in children. Acute lymphoblastic leukemia is the more common acute leukemia in children, but then that kind of flips in the older age group where it's acute myeloid leukemia becomes more common. You know, to be fully honest, I'm not a pediatric oncologist, so I don't, I'm not as familiar with that area. But from what I understand, the treatment approaches are still fairly similar at this point in pediatrics. But I, I think that's about as much of an answer as I can give at the moment. So
awesome. No, thank you. And then we have a question about a plant-based supplement and immune booster called Ambrotose. Are you familiar with that supplement, and what is your opinion?
No, I'm not familiar with that particular supplement. I would just reinforce the same thing though. I just make sure you talk to your doctor and your pharmacist if you're going to take supplements, just because the drug interactions can potentially be there. So.
Okay. And then do you have any more information on the FLT3 gene mutation?
Yeah, so the FLT3 gene mutation is one of the more common gene mutations we see in AML. And it's kind of a particular gene mutation because there's two drugs we can use that target it. One is called midostaurin, one is called gilteritinib. They're both used in slightly different contexts, but it's an important thing to know about the FLT3 because it is potentially a mutation that we can use targeted drugs for. So.
Okay. Does myelofibrosis always turn into AML, and what are the best treatments for treating symptoms?
So not all patients, similar to CML, a small fraction of patients with myelofibrosis can turn into AML, but not all patients with myelofibrosis will. The treatments for myelofibrosis are kind of it depends on your particular myelofibrosis diagnosis and on the type of risk level. So I'd say, in that circumstance, myelofibrosis, the treatments for that as well are individualized. Some people who are symptomatic do benefit from a treatment called ruxolitinib, but not everyone, but it depends on the individual circumstance. So.
Okay. And then do most cases of AML progress to CML, or do they stay in remission?
So AML does not progress to CML, but rarely CML can progress to AML. So, but it doesn't go the other way around. Yeah.
Okay. Let's see. We have some questions on transplant. So, do complex cytogenetics threaten the success of an allogenic stem cell transplant even after many years of remission?
So, if there's a high risk cytogenetics or complex cytogenetics, we do know that the risk of relapse after transplant is higher. But we also know that the risk of relapse after transplant is highest in the first year or two after transplant, and then it goes down with time afterwards. But generally speaking, the complex cytogenetics or adverse type AMLs, the risk of relapse is probably a bit higher after transplant.
For transplant, okay. And in the case of a relapse, can a second transplant be done for AML, or what other options would a patient seek?
Yeah, so most of the time, with a few exceptions, generally speaking, we will often not do a second transplant for AML, although it's again very much up to the individual circumstance and the individual treating center. So, for people who've relapsed after transplant, the first priority is figuring out how to get the AML into remission again. And that's where some of these other newer treatments can come in, or potentially clinical trials. And then in terms of the second transplant, we don't, it's a bit variable by center, but we don't do it all that commonly.
Yeah. And then just one more transplant question here. Is graft versus host disease more likely if your transplant is from an unrelated donor than a related one?
Not necessarily. So a fully matched unrelated donor, generally speaking, will have pretty similar outcomes to a fully matched related donor. But the most important factor in GVHD is the degree of the HLA match.
Okay. Are you able to speak more about whole genome sequencing and how it can help people with AML?
Yeah, so what we're doing right now is we're typically, for people with AML, we're sequencing only a handful of genes. We're only looking at 30, maybe 40 genes that we know are frequently mutated in AML. With whole genome sequencing, we're able to look at the entire genome and potentially pick up mutations that we otherwise wouldn't have identified, or pick up other genetic changes that can contribute to the pathogenesis of AML. And the idea is that in the future, if we're doing more broad sequencing, we'll be able to sort of more precisely define what people's risks are, as well as potentially identify in deeper detail what the driving factors are behind each people's AML.
Thank you. What do you know about SOT treatment for AML?
SOT. I'm not familiar with SOT in particular as acronyms.
Right.
Unless they're referring to solid organ transplantation, but that would not typically be used.
Okay. What provinces, if you know, offer new generation sequencing?
So I think I don't know in detail for every province, but I think the majority of provinces now have next generation sequencing as a standard of care for AML patients. So I'd say the majority of provinces, if not all of them, have that available.
And then you spoke on triplet therapies. Is there somewhere where people can find more information on these therapies and discuss with their healthcare team?
So the triplet therapies, these are mostly being tested in clinical trials right now, by and large. So I think really, in terms of if that's something you're thinking about, then, I think really asking your provider about, are there clinical trial options that I should, that I could participate in would be something you could think about.
Okay, awesome. We have someone joining us from Australia, and they have two questions. Australia has very low donor numbers. Where and how do you feel there would be room for improvement? And what is your view on timing for telomeres-based solutions?
So I guess the first question is about donor availability. So, donor availability is, it's improved, but it continues to be a challenge. And the most important thing with that is really just expanding the number of people on unrelated donor registries and getting more diverse groups on unrelated donor registries. So that's a major priority. So, and then, sorry, the second question?
Oh, it's disappeared from me. It was about telomeres solution.
Yeah, I'm not totally familiar with that exactly. So,
okay, no problem. Can you speak more about the prognosis of CML to AML?
So, in patients who have AML that's developed as a secondary AML, we know it can sometimes be a bit harder to treat, but again, it's very individual for, each patient. It depends on a lot of other factors in terms of how they tolerate treatment and how they respond to it.
We have someone here who's defined SOT for us. So supportive oligonucleotide therapy.
Okay, yeah, I'm not familiar with this with that particular type of therapy myself.
Okay, awesome. We have a couple more questions here. Does azacitidine prolong life in PMF turn to AML?
So in general, we do know that azacitidine treatment does, has been shown to prolong life for people with AML, in particular if they are in the kind of the responder group to it. So in general, for people in AML, azacitidine can prolong life, and it can also improve to a degree. We know that with azacitidine alone, people do eventually relapse. It doesn't produce long-term remissions, but we do know it can extend life by a period, and it can reduce the need for transfusions.
Okay, awesome. Well, thank you so much for your time today. If you wouldn't mind just flipping to the next slide, we're going to wrap up our questions here. So before we sign off today, I'd like to remind everyone of our upcoming conferences this week. We have the CLL, What It Is, When to Treat, and What's Ahead, which is today at 4 p.m. Eastern time, so in about an hour and a bit here. We have CML, What It Is, How It's Treated, and Minimizing Side Effects, which is tomorrow, November 9th at 1 p.m. Eastern time. And then we have Living and Feeling Your Best with Leukemia, How to Identify and Manage Side Effects at Home. And that one's on November 10th at 2 p.m. Eastern time. Just the next slide, please. I'd also like to highlight a special webcast presented by Ryan Clark, Senior VP of Advocacy and PR at CRG of Arsenic and ATRA Inc. And he's going to be talking about a very important topic, which is advocating for yourself and your loved one. This will also be held virtually on November 30th at 3 p.m. Eastern time. You can sign up by visiting bloodcancers.ca/events. And then last slide. So we'd like to just give a thank you to Avi, Astellas, AstraZeneca, Bristol Myers Squibb, Janssen, and Pfizer for their support in making these conferences possible. And of course, thank you so much to Dr. Stubbins for speaking with us today and providing us with this amazing presentation. And then just the last slide there for me. And I just wanted to send out a reminder that we are here to help you. You can reach us by email, visiting our website, or our toll-free number listed on the slide there. And also just please note there will be a short survey sent out to all participants after this presentation. You can please take a few moments to respond. It helps us plan events for you in the future. Thank you all for being with us today, and take good care of yourself. Bye for now.
Okay, thank you very much. Bye.
Thank you. Have a good one. Bye.